Good morning, everybody, and it's a pleasure to be here. I'm really delighted to be here for this discussion about improving the Medicare program for Medicare beneficiaries, to be here with Steve Ubel, the President and CEO of PhRMA. So Steve, you've had a really extensive health policy career. You worked for the hospitals, you've worked for medical device and technology. And so tell me a little bit, like, what brings you to the life sciences industry? Why do you care about this?
Yeah, well, I have been fortunate to spend a long time in the life sciences. I spent 16 years in the medical technology sector before joining PhRMA about 3.5 years ago. So I've had sort of a front row seat to see some pretty amazing innovations, whether it was in the technology space with the minimally invasive surgery revolution or some of the really exciting advances we're seeing in our space. I mean, you think about immunotherapies and CAR T, and we've got cures on the horizon for wretched diseases like hemophilia and sickle cell disease, SMA. It's really not an overstatement to say we're in the golden era of medicine, and I've been privileged to really spend a lot of time with researchers and scientists and the patients who've benefited from those innovations. But I have to say that 4 or 5 years ago, when my son was diagnosed with type 1 diabetes, it all sort of became real. You know, the New York Times used to have this slogan that if you don't get it, you don't get it. And I sort of felt that way when my son was diagnosed because, you know, if you don't know much about type 1, it's an autoimmune disorder where your immune system attacks the pancreas and you become insulin dependent. So at 10 years old, he's, checking his blood sugar throughout the day and, injecting insulin at every meal and at night. And I don't know how many of you have teenagers at home, but the disease really requires vigilance and discipline, and those aren't traits that are typically high on the list of many teenagers. But it's also a very exciting time in that space in terms of the innovation that we're seeing, whether it's beta cell replacement therapy or insulins that would be inert in the body and adjust to the level of insulin your body needs. It has brought meaning and purpose to my work. I feel like maybe I can play one small role in nurturing the innovation ecosystem and ensuring that we have continued medical progress.
Great, thanks. Well, so, you talked about the medical progress and, we're here to talk about Medicare. Obviously, insulin and, diabetes has also been a subject of conversation as well. But, the treatments and the cures that are, even cures, like you said, for debilitating diseases are things that maybe we never even dreamed of, or we started dreaming of them 20, 30 years ago. But, when Medicare was first established, when the drug benefit was first established, that science wasn't where it is right now. So how do you, we've heard also that sort of the innovation is, needs to also be affordable. We need to be able to get it to patients who need it. How do we do that? We'll focus on Medicare for right now.
Sure. Well, we obviously as an industry have to acknowledge that the best medicine, if it's not available or affordable to patients, is not meaningful. And unfortunately, we do have a system today where there are various incentives at work that make it harder for patients to access the medicine they need. I do think if we step back and you look at Medicare Part B and Part D historically, they have provided broad access for patients. But if you look at, again, the way the system is developed, particularly in Part D, and your previous panel mentioned this as well, patients are paying more and more out of pocket. There isn't an out-of-pocket cap, and we have distorted incentives in the system. If you look at drug spending and drug prices over the last year, they're actually growing at historic lows. They're both growing under the rate of inflation. And that's in part because we have 3 PBMs that control 80% of the market, relatively few plans, and they use that leverage very effectively. But at the same time that spending has been rapidly decelerating, you look at rebates and discounts that our companies negotiate with health plans and PBMs, they've been growing exponentially. So over $170 billion in negotiated rebates and discounts last year. And you would think if those two things were true, that drug spending was going down and rebates were going up, that patient out-of-pocket spending would also be going down, but it's not. For patients that have a deductible, their spending has gone up by, their out-of-pocket spending has gone up by over 50% in recent years. So we think that the single best change that we could make in the system is to take that $170 billion that today is flowing to everyone but the patient, right? It's going to PBMs, plans, employers, and others, to patients at the pharmacy counter to reduce their spending. You mentioned insulin, something I'm pretty close to because we buy a lot of it. The reality is that's a very competitive class of medicine where the discounts are 50, 60, 70%. Unfortunately, when the patient goes to the pharmacy, they're paying the full list price of the medicine, even though the plan may have gotten a 50, 60, 70% discount. So we have to address those misaligned incentives and really ensure that patients are benefiting from the fruits of the marketplace so they feel relief at the pharmacy counter.
Right, and certainly the polling shows and the data shows that the out-of-pocket costs, particularly for Medicare beneficiaries, are high, and we know that carries over into the commercial market. So just speaking of those out-of-pocket costs and kind of what patients might see, as we know, the administration finalized a rule on direct-to-consumer advertising. And showing the list prices. So what's your reaction to that? We've been talking about this for a while. What's your reaction to that?
I think, we agree with the administration that transparency is important. And we agree with the administration that list price is important for the reason I just discussed in terms of getting rebates and discounts to patients at the point of sale. I think where we disagree, and we've actually done a fair amount of research talking to patients about this, is that we think it's far better to have comprehensive information provided to the patient. The list price, along with what their estimated out-of-pocket costs might be, or what financial assistance might be available. So rather than a government mandate to cram this information at the end of an already cluttered ad, we believe that patients should have access to more comprehensive information, which is why pharma member companies have launched a voluntary initiative. You can already find, for those medicines that are advertised through DTC, they provide links to this further information on company websites. And actually today, we're going to be going live with a website called the Medicine Assistance Tool that will make it even easier for patients to go on this portal, search by medicine, and get access to, again, the list price of the medicine, which is something the administration has been focused on, but also an estimated out-of-pocket calculator for what their expected cost might be, as well as any financial assistance that might be provided.
Great. Well, it'll be interesting to see how patients and consumers kind of react to that. So, at the Alliance, part of my job is to kind of moderate a lot of panels. I get to sit between a lot of patients and executives from different industries, from pharmaceuticals and hospitals and that kind of thing. And, as we know, and we kind of heard a lot of different opinions on and different ideas on the panels this morning, and sometimes finding consensus on positive solutions can be it's kind of like finding where's Waldo in this town a little bit, right? And now, of course, we heard about Robert Pear this morning. It was really a huge loss for all of us. But he actually wrote about you. He said, if anyone can find areas of agreement with the critics, then your industry has taken a lot of heat. But if anyone can find agreement with the critics, or at least work productively with them, that it would be you. And he actually wrote that about you. So, how do you see moving forward? Are there areas of consensus? Are there areas where pharma, where your industry, where your member companies can kind of take proactive steps to make drugs and medicines more affordable for the patients who need them?
I know it's a great question. First, really sad news about Robert. I mean, I really believe that Robert was the gold standard for healthcare reporters and was uniquely gifted at distilling really complex information, and the whole field, I think, is diminished by that loss. One of the things I've been trying to do at PhRMA, and I talked to Robert about this in the article that you mentioned, is that historically the association's been criticized, to some degree, accurately, as not bringing forward pragmatic ideas, just saying no all the time. And I've been trying to change that. We think we have an obligation to bring pragmatic pro-consumer ideas to the table that are better ideas than some of the unfortunate ideas that we can talk about, things like importation or Medicare directly negotiating drug prices, which we think would be would fundamentally change the innovation model, the incentives, and harm patients long term. So instead, we have been bringing these, what we think are pragmatic policies to the table, whether it's addressing the supply chain issues I talked about, or taking steps towards value-based contracting, which at its core means that our companies will be taking more risk for the outcomes achieved by the patient. One of the things that's occurring in the science, as great as these innovations are, we know that not all patients are going to benefit equally, are going to respond to these tailored treatments. So that opens the door for new payment models where companies will be reimbursed for the patients who respond and not reimbursed for those that don't. But right now, we think if you step back, we talked about the rebate reform. We think we should delink the way everyone in the supply chain is paid. Right now, everyone in the supply chain is paid based on the list price of the medicine. Perhaps it's not a surprise that that's had a hydraulic effect on the list price of medicine. We have things like hospital markups. Hospitals tend to mark up the price of a medicine by 700 to 1,000%, while they're acquiring the medicine at a 50% discount. The common denominator there is that delta, we're not saying that the company's manufacturers should get that back, but that revenue, similar to the rebate problem, needs to flow to patients so they benefit and it lowers their out-of-pocket costs. So we do think there's a number of steps that we can take to control costs in a thoughtful way and to lower patient out-of-pocket costs without arresting this incredible wave of medical progress that we're seeing.
Well, Steve, I think we're out of time, unfortunately.
Thanks, Sarah.
I think we could talk all day, but thank you.
Thank you very much.
All right.